Hey, what's going on? My name is Dan Sevigny, and you are watching Recovery X, where experts, thought leaders, and people in recovery meet to exchange information, educate the public, and help solve the problem of addiction. Today, I'll be speaking with Zach Snitzer, who is the co-founder of Maryland Recovery Center in Towson, Maryland. Zach, what's going on? How you doing, man?
Doing well, Dan. Thanks for having me on.
Thanks so much for joining us. So tell us about yourself and about Maryland Recovery Center. What is your methodology over there, and what's going on for you?
So personally, I'm someone in long-term recovery. I got sober in 2007 through treatment and through the rooms. Maryland Addiction Recovery Center. So what we are is a long-term extended care treatment facility. So ideally, kind of in the continuum of care, we're able to treat people initially from detox and stabilization, or ideally through someone that's been in a 28 or 30 day, residential setting. And really fill in the gaps of what we've seen in the industry between that 30-day residential setting and either recovery housing or basic, intensive outpatient services. So what we found in terms of when we opened, there really is a huge need for a long-term level of care, treating addiction as, the chronic illnesses that it is. One of the issues in the industry is for years, based on a number of different variables, none good or bad, just kind of the way that things are. It's been this 30-day and discharge and potentially recovery housing, potentially individual therapy, potentially intensive outpatient services. And then you see like the large relapse rate. People are always talking about the revolving door of treatment. Well, the issue with treatment is addiction is a chronic illness, and we've been treating it in an acute setting, right? This 30-day model as a standalone model, not saying that level of care isn't vitally important to many people, but as a standalone care model, it really doesn't work. It doesn't treat addiction appropriately. It doesn't give people the time to deal with, core issues, underlying issues, trauma, relationship issues, sexual orientation issues, plus the major piece of finding purpose and direction, right? Employment, higher education, all those things really aren't addressed, right? Typically, the way that it's happened for years is you get stabilized in an inpatient setting. You get some very good basic treatment, right? We start kind of dealing with the issues, and then it's like, okay, now go to a recovery house and work with an individual therapist. Maybe go to the rooms of AA, whatever it is. And the 12-step rooms, while vitally important to many people for their personal recovery, are not an aftercare plan, right? And not everyone that comes into treatment needs the 12 steps in terms of personal recovery. And then it's like go to a recovery house and they have basic, important rules, but they're not literally helping people in terms of what their needs are, right? It's providing a safe, sober living. So what we found was a model that was this extended care model that was vitally important, that allows people to deal clinically with their underlying issues, can work on their personal recovery on the outside, and really start dealing with those life skills, developmental skills that are necessary in a long-term continuum. So when they're done with treatment in the safe clinical setting that they're in, they're pretty much already ready to go. They've been in recovery for a while, right? They're getting the necessary skills that they have. They discharge from treatment and they're already self-supporting. They're already employed or back in school, whatever it is. So that's kind of what we do at MARC, or Maryland Addiction Recovery Center, and kind of where we fill the gaps in terms of, acute primary treatment, and then that long-term aftercare model of whether it's individual therapy, recovery housing, outpatient services, whatever it is.
Nice. I love it. That's great. So how do you guys, on a more practical level, how do you address all these issues that you mentioned? What kind of therapies and modalities do you guys have the patients participate in?
So the benefit to this model is that we have time, and time is our friend, right? So the way that we kind of look at it is we have grown our treatment facility clinically out, right? Full-time clinical staff, full-time master's level therapists. We have 2 psychiatrists, that we have 40 to 50 hours of psychiatric coverage, nurse practitioner that can handle certain medical issues, full-time psychologists, and really developing a program in terms of CBT, DBT, trauma, like all those kind of modalities are included, but really it's a clinical philosophy of challenging patients and their pathologies, right? What is their normal reaction? And not just that, but involving the family throughout that entire continuum. One of the biggest issues in treatment is that we know that if a family gets on their recovery path, it's much it's much better to support the identified patient, right? The identified loved one. It's very difficult to do that in that acute 28 or 30-day setting, because most of the time the identified patient necessarily isn't in that area, right? The best that they can do is bring the family in for an educational weekend, but that's really not treating the family unit, right? The family unit needs to be involved in the entire continuum, in the entire treatment experience. They need to get regular sessions with and without the identified patient. They need to be referred to support groups, not necessarily, 12-step support groups, although that can be part of it, but other, parents helping parents through shared experience support groups, grief and loss groups, all these things in the community that are available, and then referring those patients and working collaboratively with other professionals that are treating the family unit in terms of individual therapists, marriage and family therapists, their own psychiatrist, whatever they need, and then working in collaboration. Like, our belief is that not one treatment facility, can treat everyone appropriately, right? There are always all these other services that are necessary to treat the identified patient and the family, right? So we have to work collaboratively, whether it's local with other providers or nationally, through this kind of collaboration and transparency of like, well, this is what's going on. One of the biggest issues is that families really don't know what to expect, right? They send their loved one to treatment, and then 2, 3, 4 weeks, or in the long term, 2 months, 3 months, all these other issues start coming to the surface because they're not able to, they don't have substances. They're not able to numb themselves, that, whether it's trauma, eating disorders, all these different behaviors, right? And the family's like, well, what's going on? It doesn't mean that their loved one isn't doing well. It means this is just kind of the natural course of what they're dealing with. So families need to be aware of that, right? And they need to be able to understand kind of the behaviors, the attitudes that their loved one's going to exhibit, and they need to go deal with that and process that and get coached and supported and understanding about what the best way to support their loved one is also. I don't know many treatment centers that are able to do that on a regular basis, right?
Yeah.
So we work collaboratively with other professionals in terms of whether they're local or not local for that whole treatment episode.
Nice. Yeah. I like that you're also talking about, treating the family as a unit and the identified patient. Could you tell us more about that and how, I think a lot of people think of addiction as like a one-person problem that affects the family, but in reality, it appears that it would be more of a family problem that expresses itself through the identified patient, as you called it.
Right. Absolutely. So think about it in terms of this, right? If you can have the healthiest family unit, right? But if for whatever reason one of those members of the family starts dealing with mental health and addiction, right? No matter how healthy that family unit is, that addiction is going to overwhelm that family unit. Health of that. So mom, dad, spouse, sibling, all these different the behaviors of the person suffering with the substance use disorder are then going to magnify, and they're going to start the causation of that is going to do a number of different things, right? So mom and dad and spouse and brothers and sisters and all these people are going to start reacting in different ways. So if you take that identified patient with the addiction, you can send them to the best psychiatrist, the best therapist, the best treatment center, right? You get them healthy. If the family unit hasn't done any work on themselves, their behaviors that have been cultivated through the loved one's addictions are still going to be there when that person returns home. And no matter how, quote unquote, I don't like this terminology, but how, quote unquote, strong that patient is, right? How much treatment they have under their belt, how much action they're taking in terms of personal recovery. You go home to the family unit that hasn't been treated, hasn't done any work on themselves, hasn't dealt with any of their issues. It's going to overwhelm all the work that patient's done, right? It's really going to set them up for failure or relapse or whatever you consider, whatever you consider success. It's not setting them up for success. So really, you have to work on. So mom and dad, what happens? The relationship strain, right? You see a lot of issues with kids who are in treatment where their parents are getting divorced, and pretty much now, granted, there may be other issues there, but they're looking at the addiction and blaming that. There might be some truth in that, right? They've never gone for their own help. You have siblings now who have not been able to get the love and attention and support that they need because everything is dealing with the addiction. Like, all these issues are still there. So it's not, yes, it is something that affects everyone, but the entire unit is dealing with that addiction.
Yeah, that makes a lot of sense. Would you say that there's sort of archetypal or typical patterns and roles that develop in a family unit, or does it kind of vary?
I think it varies. I mean, I think there's some basic things that happen. If you look at any family unit that's been touched by addiction, you'll have some basic things that will all fit into different categories. But really, it also depends on the individuals in that family unit, right? So,
Mm-hmm.
what they've been dealt with? What are, you have mom who's an adult child of an alcoholic and dad who has had trauma. It all depends on what issues that they're dealing with that then are exacerbated by the addiction. So I
Right.
think there are obviously some basic categories that have. You look at a family and you can say that, well, I'm sure mom is going to act this way, dad is going to act this way, the spouse is acting this way. There's some basic behaviors that everyone seems to exhibit typically, but I think it really depends on kind of what each individual component of that family system has dealt with and the issues that they're, to really see how it occurs.
Nice. That makes sense. So, as far as defining addiction, what is your definition of addiction? Because I know so many experts all have their own definitions, so I like to get clarity on that.
That's a good question. I don't have I don't have a quote to give you.
Mm-hmm.
The issue is, I think the issue with addiction now is that argument of between like disease or not disease.
Right.
I know it falls into the classification of a disease, so fine, that's fine with me. I know it's definitely not a moral failing or a choice. I do, there's a big issue, or there's a big movement now that you see a lot in terms of doctors and people in medicine and scientists, and they're classifying addiction as a brain disease. And I agree with that in terms of the research that I've seen. What I think they miss is that they stop there, right? So they look at similar diseases, it can be treated the same way. And I think they're missing a big component, right? I've seen some research and articles that talk about it being more of a behavioral issue. I don't think it's just that, but I think it's some of that, right? Mm-hmm. If you look at the people that have been affected by addiction in terms of the 12-step community, and you look at the spiritual aspect of it, well, you can turn that into a religious aspect, but you can really look at what is that understanding of like addiction, spirituality, connection, drive, and purpose, right? I think if you talk to anyone that's suffering with an addiction, there is some type of lack of drive, direction, purpose, self-esteem, all these things that we look at in terms of in that understanding of spirituality, right? Mm-hmm. So I think the brain disease model makes a lot of sense, but I think it's more than that, and I think we missed that. I think we missed that in terms of when people are in the last couple of years are looking at all this research in terms of addiction, for years. And one of the issues now, and just to get off on a soapbox, and I don't mind if I do, but
Preach.
So you can see me. So one of the issues now is you see that a number of doctors and people in medicine and scientists, now all of a sudden everyone wants to come out and start dealing with addiction and offering solutions and medications and treatment modalities and all these things, right? Mm-hmm. And then they want to start bashing the old school model of and I want to make another point here. Abstinence-based treatment and 12-step based treatment are not the same thing, right? They overlap, okay, but it's not the same thing.
What's the difference?
So this idea of that, well, it's all these treatment centers are using the 12-step model, and they want to bash that, and they want to talk about the relapse rates, and the relapse rates are pretty bad. But the truth is that where were all these people 40 years ago, right? The reason that we have, in terms of addiction treatment, why we've gotten to this point is for years, nobody wanted to touch addiction, right? None of the hospitals were really touching addiction. There was no training for doctors in terms of addiction, right? Mm-hmm. Very few people went into that field. So the majority of people that went into addiction treatment were people that got sober or clean through the 12-step model and did their best to open up more so-called recovery centers, not necessarily treatment centers, right? They only knew what they knew and had at their disposal was their own personal experience, right? And you would find certain psychiatrists, therapists that were trained and got into it and then kind of opened up their own. So that's kind of what we've had. Now all of a sudden everybody wants to come in and start saying, well, we're treating it poorly. Well, where were you for the last 40 years, right? You weren't there. So I don't want to be bashing treatment centers that have been using a 12-step model because that's what they had. That's all they knew, and it's helped a lot of people. But the main issue is that people in medicine look at a disease or look at addiction from their lens. That's what they have, right? So I've heard used a lot the analogy of, well, let's look at medication-assisted treatment, right? Which there are numerous. It's not MAT is not just Suboxone or methadone or Vivitrol. There's multiple aspects of medication that supports and helps people in terms of a treatment modality, right? So they look at it as, well, it's just like an antidepressant, right? you have this issue with your brain chemistry, and if you take this medication, it regulates you and you're fine, right? So they look at that in the same terms as a lot of medication assisted treatment, in terms of methadone or Suboxone. And that's true for some people, but for a lot of people, if you talk to them, what you see is, it's only regulating part, right? It's regulating the brain chemistry, but it's not changing the behavior. It's not changing the attitudes. It's not giving them purpose and direction. It's not helping them with all these other issues. So that's why I look at it as more than just a brain disease. I think that stuff is important. I think those, medications in terms of that are important tools that can be used, but it's more than that. It's not just take your pill and you're better. And that's kind of how we've been doing it. That's how a lot of people look at it the last couple of years. So I don't have a specific definition of addiction, but what I know is it definitely involves the brain chemistry. It definitely involves, behaviors and attitudes, right? It depends on how the person sees themselves and their world and their place in the world. There's definitely a trauma component in some form or fashion, right? And I think there's always a spiritual component. I don't think that means 12-step higher power necessarily spiritually, but it looks at connection and driving purpose and direction and all those things. So it's all encompassing. But if you want like a good soundbite in terms of like, well, here's 3 lines that define it, I don't have it, And the truth is, and on top of that, just to kind of dovetail, there's a difference between addiction or alcoholism as defined by, let's say, the 12-step communities, right? And then they're opposed to substance use disorder, which is absolutely a spectrum, right?
Okay. What's the difference exactly? How would one define it versus the other?
Well, I would say, the 12-step communities look at it as the hopeless variety, right? A very small percentage of people who have tried treatment, therapy, all these different things, and they continually go back to drugs and alcohol, right? They define it as the spiritual emptiness that drugs and alcohol, that's the only thing that fixes them. So they need a spiritual solution. Substance use disorder is a clinical understanding that you can meet certain criteria and you fall into that, but there's definitely a spectrum in terms of somebody that is on the low end still fits the criteria as someone that may be moderate or maybe a little bit on the higher end, right? But those people need different things to kind of overcome that issue that they're having, right? So substances are causing an issue in their life, right? They fail out of school, their marriage, their job, whatever it is, right? They have health issues. But if they can address clinically certain things that are going on, they can enter recovery, and recovery can look like certain things, right? It doesn't have to be complete abstinence, right? It boggles people's minds, people that actually go to treatment for opioids or heroin or cocaine, and then a couple of years later start drinking or smoking weed like a regular person does. Well, the truth is they were having issues, whatever those underlying issues were, whatever those clinical issues were. They received treatment. They may be still receiving treatment. They straightened it out, and they go on and they live happy, healthy lives that include some moderate use of substances, right? They use it to whatever it is. Some people can do that. A lot of people that go to treatment can eventually do that, right? There are other people that can never do that. And that's where it's a spectrum. And it's like, well, how are we really when you talk about meeting the patient where they're at, like, well, how are we meeting them where they're at and helping them to overcome certain things? Because a 27-year-old heroin addict and another 27-year-old heroin addict that are from Maryland that walk through the door of a treatment center are not the same person, are not dealing with the same issues, have different family dynamics, have different clinical issues. Like, so how are we really addressing the issues that they're having, right? We can't just address it, well, you need to stop using heroin, right? Let's sit and give you lectures about stop using heroin, right? So it's a spectrum, and everyone have different underlying clinical issues, right? Some might be suffering from trauma, some from, a diagnosable mental health disorder. One literally might be the hopeless variety that the 12 steps talks about, in terms of you can get as much treatment as you want, you can get as much good therapy as you want. You're never getting better. You're never staying sober. You're never entering into recovery. You're never going to find happiness and purpose unless you do what the 12 steps outline, right? But it's different for everyone. And it's really, I think it falls on the treatment center and the clinical staff and the entire staff to really try to figure out the best they can to help that individual patient figure out where do they fall on that. And it's really hard to tell,
Yeah.
And that's above my pay grade because I'm not a clinician. So.
Right. Nice. Well, you mentioned how AA and the 12 steps can give people, sort of that purpose, that drive in that community. What alternatives to AA are there that you would recommend that sort of have that same format?
Well, I think there's Celebrate Recovery, there's Smart Recovery,
What was the first
there's
one?
Celebrate Recovery,
Celebrate Recovery.
which is a religious one, I believe. We have a couple here through the church.
Mhm.
I know there's a Buddhist one that we don't have locally, so I'm not that familiar with.
Dharma Punks or Refuge Recovery. Is that the one?
I've heard is incorporates a lot of the principles.
Mhm.
Smart Recovery is more of a clinical, but they're all basically, it's not self-help, but it's like these mutual help or helping others or whatever it is, like support groups, right? That allow for connection. And I think a lot of people can get that outside of groups such as that, right? So
Yeah.
based on their clinical issues, you see a lot of people find it through, yoga and working out and fitness and those kind of things. You see some people find it in terms of their work life, not that they're substituting one addiction for another, but they start going creatively and looking to develop, their work life and their businesses and these ideas that they have, right? You see it in a lot of artists and musicians and so forth. They can cultivate that through that aspect of themselves. So there's a number of different ways that people can do it, but I think that that idea of that lack of connection is a huge piece of addiction, regardless of who it is. And if you ask people that have entered into recovery, whatever that personal recovery looks like, they will tell you they found it along the way somewhere.
Mm. So it sounds like, is it fair to say that the spectrum of addiction and the methodology for treatment is about as diverse as any single individual would be?
I wouldn't say it's that vast, but I'd say
Okay.
there's definitely a number of avenues, right? We know that there are certain modalities and approaches that work well for certain individuals, and we know that there are modalities in mental health that obviously work with addiction, and we know there are a number of different things, right? So, and again, it's really hard to tell. You can't tell somebody when they're entering into treatment or therapy that this is going to work for them because we don't really know. But there are definitely a number of different avenues. And in terms of a treatment center, that treatment center and their clinical staff need to be sophisticated enough to realize that those things may change while they're in that, that milieu, right? We might take one approach and it doesn't work, right? And we need to really figure out what is best for that person. But I think there are a number of clinical approaches, of support approaches, of holistic approaches that work. There's a number, right? It's definitely not one size fits all. And I don't know anyone that actually thinks it's a buzzword, right? Everyone always says that. You
Right.
go to any website, any treatment website, it's we're not one size fits all. A lot of them do the same thing.
Yeah.
It's what it's been doing for years, but there is obviously a number of different approaches that work, and it's really finding out how to figure out what the major clinical issues are with the patient, and then what approach will work.
Cool. So when someone comes into Maryland Recovery Center, they would meet with their clinician and sort of get diagnosed, and a treatment plan would get drafted, or do you guys have a set sort of things you would try first before something else?
So it's correct. So they would come in, they would meet with admissions, there would be an initial evaluation and assessment, right? They then go to their primary therapist, who is kind of their go-to for everything, right? So they meet with them at least once weekly. They also, and a treatment plan is drawn up, and that might include it includes at least one individual session, at least one family session a week, multiple groups, and then seeing the psychiatrist that we have, depending on kind of what the need is there. So that could be weekly, that could be multiple times a week, that could be once a month, depending on their clinical issues. But that treatment plan is always fluid and always changing, right? Because you see it, especially for us, because we're a long-term facility. A lot of issues really don't start coming to the surface until month 2 or month 3, right? No matter when they get to us. They could get to us after an initial 30-day treatment stay. They could come to us at 10 days after a detox based on their issues if they're appropriate. But you will see all kinds of things in terms of their attitudes, their behaviors, these underlying issues or these core issues or these co-occurring issues. And the patient, quote unquote, is doing great for the first month or two, right? And then all of a sudden, for lack of a better term, they start regressing. They're not really regressing. They're just learning how, they're just using their coping skills that they have with the issues that they have. So that means that treatment plan is absolutely going to change, right? And it could literally change from day to day, depending on what is uncovered. And then, dealt with, by the patient and the therapist and the clinical team.
So it's kind of on a touch and go basis. You're not necessarily measuring for a specific result, but you're checking in with them frequently to see what direction they're headed.
Well, it has to be. So like people ask us, like, so for our extended care program, like, patients will call up or families will call up or referrals will call up. They'll say, how long is your program? We'll say it's a minimum of 90 days.
Mm-hmm.
Typically people stay 6 to 12 months based on kind of whether they come to us and they go back home to the local area, or if they're fairly local. Some are in that continuum longer than that, and they're literally just involved with their individual therapist in one group a week, right? After they've been with us for a year or so. But people say how long? We say minimum of 90 days, but we don't know, right? Nothing magical happens at a 30-day or a 28-day mark. Nothing magical happens at 90 days. Nothing magical happens at 12-week outpatients, right? Like most of this is like based on insurance coverage and what we can get reimbursed for and all these things. The truth is that no one, who knows? One patient could get what they need and able to move on in terms of discharging and moving on with their life at 6 months, which might take another patient 12 months, right? Mm-hmm. It always has to be fluid. We always have to be kind of adapting to what's going on with that patient and their issues.
That makes sense. So I'd like to ask, how do you guys recommend that families prepare for, like, financially for treatment, and what are your services costs on a sort of standard basis, and how do people actually go through that process?
Repeat that, Dan. You froze there for a moment.
Oh, yeah, sure. So how do families go about preparing financially for treatment? I know it's very hard for some families. They don't necessarily know how much it's going to cost. What does it typically cost at your program, and how do you recommend that families plan and prepare for that?
Got you. So we accept insurance on an out-of-network basis. So it depends. So our price point is for the first 30 days would be $15,000, $14,000, $13,000 with insurance that can supplement much to a good majority of the cost and bring it down to, $3,000 a month for mm-hmm. each month. It depends really on what level of care they're at, though. Also, what I would tell families or parents is this is what we do. What we found is, one, as transparent as we can be, and is good for them so they understand. One of the biggest issues with treatment is these families that call up, facility says, I'm in network, out of network, or this is what the price is. Mm. They send their loved away, and they get a bill for $30,000 2 months later, right? And it's like, well, I didn't know, they were unaware. I mean, that puts a huge strain on the family or on the patient, right? It just sets them up for failure. What we've done is, in terms of patients that have insurance, if they call us up, we'll do an assessment on the phone. We do a risk assessment up front. What we do is give them a price in writing of what their stay would be. So month 1 would be this, month 2 would be this, month 3 would be this. If they stay longer than that, it would be this per month, right? That's in writing up front, never receive a bill in the back end. So a family can make a determination saying, okay, well, it's going to be $4,000 a month, right? We expect the patient to maybe be here 6 months. If they leave before, obviously you're not charged because we bill on a monthly basis. If they're here longer, it's still going to be this price up front, all in writing so they understand. If they say, hey, this is just not financially viable for you, it then falls on us as the provider to say, okay, well, let's try to get you and refer you to a place that's going to be more affordable. Maybe someone that's in network that does something similar, maybe someone that's out of network, but their cost point is a little bit less, or maybe it's somebody that specializes in something that we don't specialize in because it's not clinically appropriate, obviously. Mm-hmm. But in terms of financially, giving them a price up front in writing and having that document in front of them so they'll never receive a bill in the back end. We've been open for 5 years. We've never sent the patient a bill in terms of what they didn't already know it was going to be in terms of their monthly costs, right?
That's great.
It gives a very bad name to the treatment industry. And I understand why sometimes that happens, right? A facility says, we're a 30-day facility. Somebody sends their loved one there. Insurance cuts out and says they're not appropriate. We're not going to cover it until after day 13 or 14. The facility then keeps them 30 days and charges whatever the difference was. Okay, I understand it from the facility's point of view, but that's pretty shitty for mm-hmm. the family. Or they should have been advised up front saying, hey, listen, it looks like insurance is going to cut out. This is what we can do, but this is what it's going to cost. If not, let's get together a good comprehensive discharge plan and aftercare plan so there's not going to be a major gap in treatment, right? So they're still kind of getting what they need. And sometimes that's on the insurance. Sometimes they'll literally say, tomorrow we're not paying after today. That's it. but a facility still needs to outreach the parents. That falls in the facility, right? So what we found is giving patients and parents and families an upfront cost lets them to do, some due diligence on their part, figure out what's affordable, and then come back to us and say, yes, it is, no, it's not, or it's not, but we might be able to do this, because we'll obviously work with people in terms of, if, depending on their financial state, if they need some help, obviously we do a financial agreement and everything else, but everything's in writing up front. Because people have had bad experiences, and the treatment industry is not looked at in the best light anyway. So we want to figure out how can we be the most transparent for patients and families, and how can they become the most informed consumers of treatment that they can. If they say, this is not affordable, can you help me find something that is affordable, right? So they're not just going to Google and putting in addiction treatment Maryland and getting, shipping their loved ones off across the country or whatever it is, and then they get discharged with no discharge plan, and they're on the streets, right? Like, you see that in a lot of these different areas. Helping them be an informed consumer, and then doing our part to, if they can't come to us, finding a place that then fits both their clinical and financial needs. That falls on us, right? You see that in the other areas of medicine. Why don't you see that more often in addiction treatment? So we just kind of think that's our place to do that as a provider.
That's great. Yeah, you guys have been having a lot of success lately, and I'm sure that is definitely part of it, if not, contingent on it. Sounds like you will really take care of people no matter what their situation is, and make sure they get to the right place, even if they can't afford your services. So that's really great that you guys do that.
Yeah, we try to. We have, when we open. I mean, we're family owned and operated, right? We're not this huge conglomerate of places. We don't have call centers. There's 3 admissions people. They're literally in the next offices, next door to mine. The staff was trained to and again, things happen. We're not great at it all the time, right? If you get 6 calls coming in at once, I'll pick some up. We have, one person that's out doing community work. She'll pick it up. It doesn't happen all the time, 100%, although I wish it would. But they've trained to be, no matter who that person is that's calling up, whether they are someone that can afford the most expensive places out of pocket and they have millions of dollars, or they are local with no resources, no insurance, no family help. They literally have not a dollar to their name, to take the same amount of time on the phone and to get them the resources that they need. And that doesn't mean saying, hey, here's 3 numbers of a SAMHSA list, which most of the time is outdated anyway, right?
Yeah.
But say, hey, here's a facility, here's a contact, we can make the call together, right? And a lot of people don't know the resources, and we do, right? There's a resource not far from us that's a 500-bed male facility. It's absolutely free, right?
Oh, wow.
But
What's that one called?
It's called the Helping Up Mission in Baltimore. It's an incredible program. It's not the most clinically driven program. It's more of a spiritually, but it literally will keep people there for 2 years, and it's a beautiful facility, right? Now, they're not appropriate for everyone. They're not appropriate for co-occurring or dual diagnosis or major psychiatric issues. But for somebody that doesn't have those things, that doesn't have resources, they're an incredible facility, right? I have friends of mine that have gone through there. But a lot of people don't know about it because they don't really advertise, because they don't have a marketing budget, right?
Right.
But we give them personal contacts and say, hey, call this person, this woman, this guy. They work in admissions, ask for them, use our name, and that takes 10 minutes out of our day, right? You can't put a price on a human life based on what insurance they have or how much they have in the bank, right? Like, addiction affects everyone. Well, then as a provider, we should do it as best we can to get whoever it is the resources that they need, right? So we try to do that as best we can.
Absolutely. That's great. You mentioned that there are some sort of problems in the industry as far as the marketing goes. And I know that you are very active in sort of leading the push towards ethical marketing in addiction industry.
Sure.
Could you describe the problem and it sounds like you sort of did describe the solution already, but if you have other stuff to add as well, would be interested.
Well, I mean, yeah, sorry. I don't know if I'm leading the charge by any means, but we're pretty outspoken. The good thing that we can do, again, is we're family owned and operated, right? The decisions fall on the three owners of the company, which is myself, my wife, and our executive director. So we can afford to take the hits when they come. We can be outspoken, right? Not everyone in the industry can, but the truth is that there's a ton of problems in terms of, obviously everyone knows about the Google AdWords and the marketing, right? Everyone knows about the patient broker.
I'm not sure they do. People that watch the show may not know. So if you want to tell us about it.
You have the pay-per-clicks and the Google AdWords in terms of like facilities representing themselves online, and paying to be top of mind in terms of top of Google, right? So if somebody Googles addiction treatment Maryland, you're going to have a facility in California show up at the top. The major problem there is somebody clicks that and they're getting somebody that's, 30 days to 60 days, 90 days sober with no clinical understanding, that are basically presenting themselves as we're doing a clinical assessment. The consumer is no different, whether that's done by that person or a therapist. They say, if you meet criteria, of course you meet criteria, because they just want you through the door. And then you're sending your loved one off to, and I'm using California as an example because we're in Maryland. So you're sending your loved one across the country to a facility that you've never seen, to a clinical staff you've never talked to. We just put out a blog on this one. So, and again, it's not apples to apples, and I want to be very clear on that. But if you want to equate addiction as a disease, let's look at cancer as a disease, right? Mm-hmm. You have a loved one that gets diagnosed with stage 4 cancer, and the truth is that nobody that comes to the door of addiction treatment are stage 1 or stage 2, right? We're all in stage 4 when we walk through the door. You have a loved one with cancer, and what happens? You go to the doctor, you go to your primary care physician, and your primary care physician says, okay, well, I'm gonna refer you to this oncologist, right? This specialist. And then you as the loved one take your loved one and go meet with that person. You ask them questions, and you probably take a consult with 3 or 4 other specialists, right? And you feel you have your questions answered. You go see the hospital. You go see you meet the physician. You meet the staff, and you ask questions, and you get a comfort level. And you say, okay, well, we're going to have Dr. So-and-so treat my 22-year-old son with stage 4 cancer, right? And then you get a full follow-up understanding from that physician in terms of what their care is going to look like. We're going to give, we're going to remove the tumor through surgery. We're going to give chemo and radiation, and you're going to get this many years of follow-ups, and you're going to change your diet, and we're going to give you all these recommendations. And then obviously it's on the patient to follow those recommendations. But you kind of know what that's going to look like, right? In addiction treatment, we go to Google, we call them, we talk to a guy that says, well, I went through it myself. It looks like we can take your loved one. You've never met the owners or the clinical or the medical directors. You've never spoke with a therapist. You went to a website and saw a pool, right? Like, if this was cancer, you would be flying with your loved one to see that place, right? And you wouldn't say, okay, you're going to admit necessarily. You're going to say, okay, well, we're going to go see another place that we saw, right? We're going to go look at, Johns Hopkins and Sloan Kettering. You're taking time off work to go look at those places. Well, you see the overdose rates, you see people dying from addiction. The mortality rate for addiction is similar, right? But because I think of the stigma and the way that we've always, as a society dealt with addiction and addiction treatment, no one questions the fact that we're sending our loved ones to a place we've never seen, to put them in the care of people we've never met or had a conversation with, right? And then the consumer gets upset when it doesn't necessarily go well. And sometimes it doesn't go well. You can send them to the best treatment center and they're very resistant or whatever happens. But the truth is that family should be walked throughout that entire process. They should expect certain things. They should know that it may not go well, but this is how you can support your loved one. And this is what we're going to do if they leave, right, against advice. This is why we're going to support you if they do that. This is how we can get them back into treatment, whatever it is, right? But the marketing has always been just get patients through the door. Patients are looked as commodities, and we can't do that, right? This is a healthcare business. And yes, businesses have to stay open and everything else, but there's a whole other issue with insurance and everything else in terms of reimbursement. But we have to look at people as people. We have to give them the care that they need, right? And this whole marketing push in addiction treatment has not been looking at people like that. They're looking at people as commodities, and insurance policy is not okay.
Yeah, absolutely. So how does one in that search find?
I think I may have lost you there.
Can you hear me now? Yeah. Zach? Oh man, bad internet.
Yeah, you were frozen for about 3 seconds.
Oh no, okay. I was actually just standing very still. Just kidding. That's a bad joke. Um, so when someone's looking for a treatment center for their family member, how do they recognize signs of a good one and warning signs of a bad one when they're calling through Google or other avenues that they're going through?
I would question anyone that is trying to get you through the door right away.
Asking about insurance right off the bat, stuff like that.
Yeah, obviously anyone that is offering to fly you anywhere or pay for anything. I do know that, for example, so Blue Cross Blue Shield in Maryland on an outpatient level, not at an inpatient level, but they're doing certain things to make it more affordable. So they're allowing certain facilities that they are in network with in network with in Maryland to waive deductibles and out of pocket costs. So that's legal, right? But any facility that's willing to waive deductibles or out of pocket costs, buy you a plane ticket, any of that's obviously is a facility to stay away from, right? A facility should invite you in and invite you to get a comfort level with them. They should say, come in, meet us, tour, right? Meet our staff, understand what treatment's going to look like, right? That's what you should be looking for, right? You should be looking for a facility that if you call up and if they're not in network with you, right? They're literally giving you options that are in network, and they're giving you an understanding of those options because they know who they are. They feel comfortable in referring. They're not just sending you a list, right? Those are things to ask. You should ask about what the expectations are, what the family programming looks like, how involved is the family, right? A major push by a lot of facilities that are not on the up and up are they know that if mom and dad send their son across the country, mom and dad can't check in, right? Mom and dad don't know what's going on. So mom and dad half the time aren't even getting calls. Well, the patient didn't sign a release, so we couldn't call you. Like, I'm sorry, but if an 18-year-old, female is on their parents' insurance and they're like revoking releases of information, it's that facility's responsibility to get them to sign. Use that as a clinical tool. That person is there because mom and dad, and they're going to be probably returning to mom and dad. Mom and dad need to be involved, right?
Yeah.
Our industry, the treatment industry, for years has taken the path of least resistance. Sorry, it's too hard. I can't get an 18-year-old to sign it for mom and dad, although she's living in their basement and they're paying for all her stuff, right? Like, we just don't challenge patients. We don't challenge, we don't push back. Well, it's too difficult. And it's not that it's too difficult. A lot of the times is they don't want mom and dad involved, right? If they're not on the up and up, if they're not, any good, ethical, quality treatment center wants the family involved. So if a family is not involved, that's a huge red flag, right?
Absolutely. So if there's one thing that you could say to every family, parent, spouse of someone suffering from addiction, what advice would you give them?
I would advise them to become an educated consumer, right? Don't. I understand that when these things come up, it is a crisis, right? And we want to get the loved one the help that they need. But you need to become an educated consumer. You need to vet these programs. You need to start speaking out about addiction and not worried about the stigma or what other people are going to think about it, right? If addiction is a disease, your loved one is sick, just like if they have cancer or heart, disease or diabetes, you need to, someone that's in recovery, another family or multiple families that have dealt with addiction. Ask questions. Go to a friend that's a therapist, or just outreach a therapist, right? Find an addiction therapist because they've also dealt with this issue with their clients. Vet programs, ask questions, go see these places, right? Go with your loved one and meet the people that are treating them. Again, if this was cancer, and we're in Maryland, if my wife or child, I am going with them, I'm taking off of work, I'm going to Hopkins, I'm meeting the team, I'm feeling okay that this is where my loved one's going to get treated, because if they don't, they may die, right? Addiction is no different. So we need to take that time and we need to ask questions and vet and become educated and understand that where I'm sending someone, this could be life or death. So I better invest. It's not just about finding the cheapest option to send them somewhere so they're out of my hair, right? We need to get them the highest quality treatment that they can get, and we need to feel comfortable that we're sending them to people that we know are treating them well, and we know what the treatment's going to look like, right? We need to, as the consumer, you need to demand transparency for the services.
That's great advice, and they're taking a great first step by watching this interview and watching Recovery X. So we really appreciate you giving us your time today to speak out on this important issue.
Well, I appreciate it, Dan. I appreciate the time and the opportunity.
Absolutely. Is there anything else that you want to make sure we talk about today, or?
No, I mean, I think that's it. I think we covered a lot. So
Yeah, definitely. If people want to find you, where can they reach out to Maryland Recovery Center?
yeah, so our website, Maryland Addiction Recovery Center, the website's marylandaddictionrecovery.com. My information's on there. Email is first initial last name, so Snitzer at marylandaddictionrecovery.com. Numbers on the website, and we regularly get requests and information and questions that have nothing to do necessarily with our services, but similar to these questions of, well, this is the situation I'm in. We're always happy to kind of reach out and respond and help and support if we can.
Awesome. Thanks so much, man. I'm going to close out the show right now. For everyone watching, please remember to like, share, and subscribe to Recovery X on Facebook, YouTube, and iTunes. We'll leave the links for each of those in the show notes, as well as a link to Maryland Addiction Recovery Center. If you or someone that you love is suffering from addiction, please reach out to us at Recovery X by sending us a message, and we will get you connected with an expert who can help you right away. And if you like what we're doing here at Recovery X and want to support us in solving the problem of addiction, you can donate to the show at patreon.com/RecoveryX. I'm Dan Sevigny. You're watching Recovery X. That was Zach Snitzer from Maryland Addiction Recovery Center. Zach, thanks again, brother. Really appreciate it.
Absolutely, Dan. Thanks so much.
All right, man. Have a great day.
You too. Bye-bye.
Later.